John, hi, and thank you so much for joining me on Faces of Digital Health. Today, we are going to discuss the data layer of AI. In some of the previous episodes, we already mentioned how AI is this black box that we don't really know how it works, which also makes it seem magical. But at the end of the day, the data layer is still what matters the most. If we want good outputs, then the inputs need to be correct. You're the SVP of commercialization for IMO Health, which, if I'm not mistaken, is a company with a long history in clinical terminology. So let's start there. How is the company doing today? How has it evolved in the last over 20 years, providing medical terminology and being one of the pioneers on the US market for that?
Great. Well, thank you for allowing me to have this time. I'm excited to have this conversation with you. Yeah, I'll give a brief history of IMO and our role in healthcare, not only domestically here in the United States, but also internationally as well. We've actually been around for 30 years. And for those 30 years, we have been providing our terminology to clinicians to help them capture complex clinical concepts within their electronic health records. I think an example, if you're at Johns Hopkins, Northwestern, where I am here in Chicago, and the physician is documenting your diagnosis, saying, hey, this patient has diabetes due to rainbows and unicorns. They're not free texting that. They're not typing that abstractly. They're searching our terminology, finding that clinical concept, selecting that, and then we're bringing that clinical concept and all of its related code mappings that drive billing and analytics into healthcare and pushing that back into the EHR data model. We do that about 12 billion times a year, that search and that response. And the reason we've gained that market share and that trust of the enterprise healthcare is that we accomplished two things at once. We allowed physicians to express themselves in the way that they learned in residency and fellowship, but we also mapped to the code sets that are necessary to drive that billing and analytic function. So the CFO was happier that we were improving the billing outcome for a health system, and the physicians were saying, now I can finally document what I need to in the EHR. So we've been doing that for that last 30 years, and that gives us a deep understanding of how physicians document, how they express clinical conditions. It allows us to be on the forefront of that terminology and that reflection of how medicine is expressed. And it's now we're applying that to our AI partners across healthcare.
I have two follow-up questions in that regard. When we talk about terminology, it's never static. It gets updated. If we look at SNOMED or other terminologies, you constantly need to kind of update the connections because codes may change. So how big of a challenge is this for you, and how is AI changing the work for you and how those updates are made?
It is essentially our entire company's objective is to maintain that clinical terminology, abstract it from our partners so that they don't have to worry about it. That's why we're partnered with every over 130 electronic health record systems so that they don't have to maintain that terminology and that semantic layer. We have built our terminology to both map to things like SNOMED and ICD-10, but it's designed to be clinician friendly and to earn the trust of the clinician. So ICD-10 is designed for billing. SNOMED is designed more for research and categorization. IMO's terminology, while it maps to both of those, is designed to be clinician friendly and earn the trust of enterprise healthcare providers. AI is certainly helping us, but it's only helping us because we've built a very thoughtful governance around terminology and clinical concept development. AI models could certainly build an ontology. OpenAI and Anthropic have demonstrated that. But without the clinical informatics infrastructure and the governance around that, they can, as we know today, can hallucinate and create a clinical concept that may be irrational or not useful for a clinician's daily use.
Mm-hmm. And what differences or what kind of evolution are you observing with within the healthcare providers and their IT systems and their data layers with the rise of AI? The US market is very, very advanced when it comes to healthcare digitalization due to the historic development of how this was supported financially. So in Europe and in some other countries that might not be the case, which also means that the data layer might be messier. And one of the speakers from
Yes.
Europe in the episode that I just published mentioned that because of AI, the data layer is going to need to be invested in more, and the data will need to get cleaner. So to which extent do you see those changes with your customers, or what kind of problems are arising because of the need for, clean data?
Yeah. I mean, given the US investment in the electronic health record over the last couple decades, there has been an establishment of a data layer that is more robust than I think in some other countries. That being said, I think what AI is establishing is that having a data layer and structured data is important, having that data infrastructure, but having a semantic bridge or really semantic understanding of that data over time is increasingly important to unlock AI's capabilities. AI is really powerful at assessing large amounts of data at scale that no human ever could. But that its ability to understand the nuances of or the semantic interpretation of that data over time is still very limited. And that's where IMO can play a very important role as a semantic bridge for your AI model. We're doing that at scale with ambient vendors in the United States. We have most of the top ambient providers are using IMO to support their AI models and the interpretation of the data that they're getting from the electronic health record or abstracting from a patient visit. And our health systems, as they're starting to deploy AI, are recognizing that they need to have that semantic layer so that they can understand that the sugars that was documented in the 1990s still means diabetes today. So
Mm-hmm.
having that longitudinal understanding of terminology is extremely important as AI consumes this amount of data.
Mm-hmm. And how do patients come in the picture? When your team reached out, they basically emphasized that now patients are also coming into the doctor's office with information that they pick up from AI, which obviously is not necessarily in a clinical language because the clinical language is very specific. And one of
Yeah.
the things that's also happening with AI is that, the discharge letters, for example, are being translated from the clinical to the lay language. So how does that lay language and the desire to add patient-facing data or patient-generated data into the EHR, what kind of semantic and terminology issues is that causing, and how are you already looking at that problem?
So we've been looking at this problem for years. Bridging the two lenses of a patient-friendly terminology and an enterprise-related terminology is something we have focused on for a long time. We have patient-friendly terminology available. We deploy that with large EHR customers today to help their patient engagement tools. We're also supporting it in with our ambient providers. When a physician and a patient talk about breast cancer, that's a simple term, but that is not going to drive the necessary clinical pathways, clinical complexity, or even billing that's needed on the enterprise side. So we need to ensure that we can understand breast cancer and then map it all the way back to breast cancer, metastasized to pelvis, stage 4, that truly is needed for the enterprise healthcare side. So patients have always been bringing new information into the physician office. Our role in healthcare is to help interpret that patient information and translate that back and map it to the clinical terminology that's needed in enterprise healthcare today.
Mm-hmm.
And we want to be the
How
company that provides that linkage.
how do you make sure that, or how do you work with errors when they occur? So I'm really glad that you mentioned ambient listening vendors, because it's the fastest adopted clinical AI category. And the problem becomes when a scribe model mishears or over infers a diagnosis, and then that error basically becomes part of the patient record. It has
Yeah.
billing consequences. It can't be easily changed. What are the safeguards there, or what's your advice to hospitals or patients that notice that there's an error that needs to be repaired?
Yeah, I think you're correct that it is something that enterprise healthcare is watching very closely. On the billing side, the chief financial officer is not going to want to impact anything for that. On the clinical side, which is even worse, we don't want to infer and go down the clinical pathway, because if the diagnosis is not correct, that begins a daisy chain of interventions that may delay the appropriate care, or worse, provide inappropriate care. We take a very thoughtful approach to content creation, and now we're applying that to the data normalization and the semantic interpretation. IMO employs about 60 clinical informaticists and physicians that help us, that have built our clinical governance plan that we apply to any new term we create in any semantic interpretation that we make. And then we deploy that through our knowledge graph, so AI models can leverage that governance and apply that when they're doing inference over a patient's medical record. So, for example, while the patient said diabetes, here is the medications that are associated with diabetes. Ensure that those are in alignment before you push that as the working diagnosis back into the EHR. So we're providing semantic guardrails, and through our knowledge graph, some cross-domain relationships that allow AI models to ground themselves before they make a recommendation back to the physician or push that data into the data model.
What worries you most, when it comes to the increasing level of automation in healthcare? We so far most often focused on hallucinations and the problem that we just discussed, so the mishearing and misdiagnosis because of the scribe. But what about omissions, when AI decides that something is not clinically relevant, but it actually is, and that then changes the whole picture on how clinical decision support is going to react or advise to clinicians? How do you deal with that?
Yeah, I think for us at IMO, I think omissions is a critical risk area. And I think for us at IMO, our understanding of the past that physicians have used our terminology over the last 30 years allows us to highlight essentially relevant targets for an AI model to pay attention to so that they don't miss something. So we can provide essentially saying, hey, this is the most common way this clinical condition has been expressed, and the hierarchy that you may want to evaluate of that clinical condition so you don't miss something when you're interpreting a patient's chart, an AI model is interpreting a patient's chart. So our goal is to provide true grounding to those AI models, leveraging that deep understanding of how clinicians have expressed care for the last 30 years. I think that benefits both the hallucination on the other side, but can also help guard against omissions by saying, have you evaluated all of these other potential ways that this clinical condition could be expressed?
So there is a way to not worry about that.
I don't think we should ever not worry about it. I want to be clear. AI is entering into the clinical workflow. I think thoughtfully. It's not. I mean, in our work with health systems across the country, they're tackling some more of the administrative functions first, and they're being very thoughtful about integration into the clinical workflow. Even our Ambient partners are just now beginning to push more and more structured data into the EHR that will fire clinical decision support and care pathway development. So I think we're just beginning that journey. So I don't think anybody's rushed into it yet.
Mm-hmm.
But we're playing the role of providing that grounding and to help those AI models be effective.
Where do you see that healthcare providers struggle most when it comes to the cleanliness of data and data structure?
Great question. There's a lot of opportunity. I would say, for the last 30 years in the rush of the EHR deployment, we've captured a lot of data. We see patients with problem lists that are hundreds of problems long, as one representative example. So we have essentially an abundance of data. Now, AI can synthesize that really quickly, but that's also a lot of essentially token burn and AI use that we may not need. So we're working with a lot of our health systems to cleanse that data using an understanding of heuristics that have been built on our terminology to say that this problem is no longer relevant. An AI model does not need to interpret that and burn computational power to do that. So I think I view the world in two different ways: an abundance of data that has been captured maybe and never cleaned over the last 30 years because there wasn't essentially a demanding need to do that. And now we're looking in the unstructured data where you need really that semantic bridge because of the way that patients may express themselves are different than the clinical kind of nuance that we've captured in that clinicians have needed to use over the last 30 years.
Mm. You mentioned earlier that you work beyond the US after 30 years. That's understandable. So, what kind of differences do you see on different markets for you as a company? How is it for you to try to help and address the same issue with the data
Yeah.
quality?
So we work in, I think, over 20 countries where English is used as the documentation standard in electronic health record. So within the NHS, within countries throughout the Middle East, Singapore, Australia, and so on. In the end, I think the same concepts are relevant, that we need high quality data capture. Now, the coded representation of that data differs by country and the complexity of that coding. But in the end, most countries are recognizing that they need to capture that structured data to better reflect the acuity of their patient population. And just where they are in that journey differs a bit, but most of them are still moving to a much more nuanced data capture model so that they can resource allocate in a more sophisticated way. So I will only, across all countries, I'm seeing an increase in data complexity at the moment of data capture, and the coding complexity behind only increasing and going in that direction. So we've been supporting countries that are relatively early in that journey to the most sophisticated, like I mentioned, here in the US.
Mm. And what do you think that that means for healthcare providers and the workforce structure? Who's going to take over that data governance and that increasing complexity? Is it going to be new profiles, new workers, new types of data specialists? Is there going to have to be a different education given to clinicians in terms of how they document things?
Great question. I think clinical informatics will be on the rise across the country or across the world. I think that is evident already today. We at IMO are under the belief that we should abstract the clinicians from that complexity. That's been kind of our objective here at IMO, is like, I don't need the clinician to think about the 3 SNOMED codes to capture. I just want them to say, that's what's wrong with this patient right now, and move on. That's where good clinical informatics can benefit both the back-end analytic infrastructure and the front-end end user of at the clinician's bedside. So that's our point of view, and that's what we build our terminology and our tools to do.
I love that, because I sometimes feel that there's the answer to all the digital health problems is the clinician should educate the patient about AI, the clinician should know the codes, the clinician should, and I'm like, my number one wish from the patient perspective is for for my doctors to not quit their jobs, right?
That's exactly
And
right.
but it is true. But it is true at the same time that it is the doctor's office where patient questions around AI are most likely going to arise.
Yeah. Yeah, I think for the first time in a long time, I'm seeing the health technology market abstract more than it's putting on to the clinicians. And I think that's a very exciting time. But we have to do that very thoughtfully so that we don't erode the data infrastructure that's going to unlock analytics and the necessary resource allocation behind the scenes. So I'm excited that IMO has played that role in the EHR, and now we can deploy that same level of thoughtfulness into some of these emerging technologies, like I mentioned, ambient or autonomous coding in the United States here today.
Mm. Um, After ambient scribes for clinicians, there's also providers that have popped up on the US market for patients, so that the patient also records the discussion with the clinician and gets different recommendations on what the next steps should be for the patient, and what potentially the patient should ask, etc. How is that impacting you? You know, that entrance of content generated from patient chatbots at home to EHRs. I know we discussed this earlier, but still, it's a big question.
It is a big question. And I think patients have always been bringing information that they've brought from their own context to their clinician. My wife's a partner is a physician here in Chicago, and I think AI has supercharged that. I think, but you've seen historically that most healthcare providers, enterprise healthcare providers like health systems, are reluctant to bring that information into their own data model, right? I think we need to break through that fear because there's valuable information that is being captured in those conversations, but we need to bridge it from a patient-centric lens, like we talked about earlier, to something that can be ingested by an enterprise data model and then related back to the clinical data that we've been capturing for 30 years. So
Mm-hmm.
again, to me, that's the semantic bridge that needs to be built, and that's what we're focused on. While
Where,
we're,
where, the,
oh, good, good.
where does the fear come from? You mentioned
I think
that they're afraid of that ingestion. Why?
I think they've had historically that's been data that has not been curated directly by those health systems, and because of the impact on so much of their reimbursement and the clinical workflow, there has been some reluctance to allow external data into your EHR, for example. Interoperability has been chipping away at that for years from the federal level. But I do think we're missing out on valuable information as long as it's captured and translated semantically appropriately. That could be very useful for the health systems to drive improved clinical outcomes and potential financial outcomes as well.
Mm-hmm. What are your observations related to the friction that is starting to pop up because of the bigger data accuracy? So I read that some scribes, you know, can capture and can create more billing for a specific encounter between the patient and the doctor than before. So before, when things were done manually, doctor would just say that they did this exam and that exam, and they would bill for that. But actually, the ambient scribe that captures the whole discussion actually captures that more things have been done, which means that
Sure.
the healthcare provider can bill more. And I'm just wondering, because I'm obviously not from the US, how is the market reacting to that? Is the pushback from the insurance companies coming from the point of view of changing how much something costs or will get paid for? Is there a larger number of denied claims? And how do you see your potential role in that clarity on what was actually important?
Yeah, that's a big question. Um, that friction has existed since the emergence of our fee-for-service billing system here in the United States, and I think it will not. AI may be accelerating some of that friction or increasing that friction, but it's not net new. Um, I have, and IMO has an opinion that we should capture the most clinically accurate documentation on what happened on that patient. It should be as specific as possible. It should be reflective of that patient's true acuity. Only that information, after it's been captured at scale, will allow us to interpret our financial models and our clinical models. In the absence of that, you're working in asymmetry and you're essentially not really understanding the population that you're dealing with. So while there is short-term pain depending on who you ask, but while there is short-term friction, I think it's only going to benefit us to have a much more accurate data capture over time.
Mm. So you're optimistic.
You have to be, right? We've been in this journey for a long time. I'm optimistic for a lot of reasons. I think, like I said, I think for the first time in a while, in aggregate, the health technology market is abstracting from the clinician workload, giving them more focus on the patients. I think we are entering a period where whether it's patient-generated information and more accurate documentation in the EHR, we're going to have new data that we've never had before, hopefully more accurate. Now, how quickly the economic models and the governance models evolve to that will be interesting over the next few years.
Mm. Is there anything that you feel is not being discussed enough when it comes to medical terminology and the impact that data has on AI development?
I think that there has been a renewed focus on clinical informatics, specifically over the last probably 12 to 18 months. The excitement of the AI hyper bubble has started to meet with reality of the messiness of clinical data. And we are certainly seeing at our company a lot of interest from leading health technology companies around, hey, we are investing in AI, but we need to make sure that investment pans out. And we can't take the time to wade through this messy data without a semantic layer to move faster. So I think this is the next phase of kind of clinical informatics, and now it's being applied to AI. So I'm very excited that this conversation is now shifting back to the core of data quality and semantic interoperability. So it's
So
an exciting
what do
time.
you see? What do you see is still the most common misconception around the capability of AI? You mentioned that we're starting to meet the reality and the hype is kind of settling down.
Yeah, I think as it relates to enterprise healthcare or the most complex healthcare delivery models, the applicability to very nuanced diseases, rare diseases, that last 20% of the care delivery model here domestically we've kind of hit a threshold of AI model performance there. I'm sure it will continue to improve, but I think for large health systems that we work with across the country, they're going to be reticent to inject AI into those clinical workflows until that understanding of that clinical data has improved. So I would say that's one big function. I think the other area of focus will be governance in general around AI. As health systems look to incorporate AI vendors into their tech stack or build their own AI models, it's going to require new forms of governance and new forms of a way to interpret their performance that I think go beyond the traditional procurement and governance models that they've had today.
Mm, yeah, I guess one of the things that is sometimes mentioned is the proliferation of solutions that's possible with vibe coding
Yeah.
and potential new data silos and potential new interoperability issues. Does that also have an impact on you and which systems you can reach that need to be incorporated so you have the full picture about a patient?
I mean, again, that kind of comes back to that semantic bridge. If you have data silos that have been created over years, some in the cloud, some on-prem, some 20 years old, some up to date, you're going to need to essentially semantically align that data to unlock that AI model's performance. And so we're seeing a lot of focus on data normalization and standardization of your data asset across those data silos to enable that AI model to interpret that data quickly and limit those hallucinations. And then having essentially a governed ontological model that your AI model can trust and can hit against so that if a hallucination does pop up, you can ground it with something that's trusted, are two recommendations that we provide to our customers today that they need to think about as they're building out their AI maturity model.
Mm. We're slowly wrapping up the discussion, but if there was one problem that you could get rid of in the way that you do things or in the way that, new problems are popping up with AI, what would you wish that, could be omitted or would not exist?
Good question. There's many in this environment. So I would say if,
You can do a list.
for me, the number one counsel I provide to our customers as partners for them, whether it be a health system or a large health technology vendor, is that we recognize the AI investment cycle is going to continue, but you need to be thoughtful about a grounding source of truth for that. And in the absence of that, I think you run the risk of losing the trust of your clinicians. And once you do that, it's hard to come back. And so the excitement is very high right now around AI, and I'm as bullish as others on it. But the moment you try to bring that into the clinical workflow, you better have a trusted source of context that you can rely on. And if you don't, I think you're gonna frustrate when it misfires on that 20% of that patient population you're caring for.
Mm. Let's kind of dig into that a little bit more. Absolutely, sources are important, and I sometimes wonder to which degree is it going to be harder and harder to get to the right sources because everything is done in the direction of algorithm optimization. Even scientific papers might have titles that are going to be SEO optimized and will
Yeah.
be more catchy. So I'm sometimes wondering to which extent are we in danger of getting into a tunnel vision because of the way that data is curated with AI and where it's picked up on, and how basically it doesn't even make sense anymore to have a website with information because people won't come to that website. They're just going to go to LLMs for questions. So it's a risk investment to do specific content on your own platform.
I think that's a valid assessment. It kind of gets back to your question around omissions as being a risk as we get tunnel vision in some of the LLM's interpretation of data that's out there. That's one reason, as we talked about the balance IMO has around its own content curation. We certainly use AI, but we have that large number of informaticists. And because we are used by so many clinicians, we can get signals from the market around emerging diseases even before maybe some of the publications move them out. So we're acutely aware of that, and while we need to ensure that we have 80% covered, we're also focused on that 20% of rare diseases populations that you have to build into your governance model. If not, you're gonna dumb down your output. So we not only built that way, but we invest that way continually to ensure that we're not just taking care of the most common use cases, but really everything that enterprise healthcare and life science needs.
Hmm. Well, John, thank you so much for sharing all your insights. Is there anything else that's on your mind that you feel is worth sharing with the audience globally?
I'm, like I said, I'm very bullish on where we're moving. I think we're at an inflection point, though, of recognizing that data quality is important, but also the ability to reason over that data has to be grounded as well. So you can invest in the data, you should invest in the data quality infrastructure. And now you also need to think about what is your data reasoning, what sources of context are you using to power the data reasoning layer of AI as well. And those two will, I think, make the most advancement in the near term for us.
I love it. Always love the critical perspective, because I'm sure that there's so many things that we're still not even aware of in terms of where things might go wrong. So it's good to be mindful on the way there. So, John, thank you again, and hopefully we'll speak soon.
Thank you very much. Talk to you soon. Bye.
Okay.